Well, welcome everybody to this meeting and returning to human testing in the lab and the field. Put on by the Physiological Society, chaired by me and with much help from the group you can see at the bottom of this slide. So I'll start by thanking them and then I'll pass you over to Andrew Mackenzie, who will give you just a quick briefing on what we intend to do. So over to you, Andrew.
Thank you, Mike. Just to make everyone aware, the video is being recorded and we'll use that to type up notes from this meeting. The chat function, which you'll find at the bottom of your screen if you click on the word chat, we will use that to record the discussion and any questions or comments that you've got. Now we have currently about 600 people in the meeting, so it won't be possible obviously for everyone to contribute verbally or on video, although we'll try and get as much in as we can, but we would encourage you to use the text chat function to make sure that we capture any thoughts or questions or queries that you've got. And what we will do after this meeting is make sure that the text content in that chat is saved and recorded as part of what we do. Every participant is muted. Currently, if people want to speak or contribute anytime, please click the raise hand button, which if you haven't used Zoom before, you can find by clicking the participants button at the bottom, and then there is a raise hand button at the bottom of that participants list, which appears on your right hand side. Click that and then we will know that you want to come in and speak, and then we will unmute you and also ask you to put on your camera, which you are able to say yes to or no to, depending on what you would like to do. And that's all from me. So over to you, Mike.
Thank you, Andrew. And again, welcome to those people who are still joining us. We're just over 600. And so the plan is to go through these topics. Everybody who's signed and registered for the meeting has received the slide deck, and this is not intended to be a lecture by Mike Tipton for an hour and a half, which will be a relief to a great many of you who have heard me speak. It really is just to get stuck in and have some discussion and reach some consensus on each of these topics as best we can. Now, there's quite a lot of high-level information out there, and there's quite a lot of specific information on certain of these areas. So we won't go into great depth in some of these areas. Where there appears to be quite a big gap is what we as physiologists can do. Lots of information for the healthcare sector, but much less for what we can do as a group and how we should go about what we do. So we'll talk a bit about that as we go through. As you've heard from Andrew, we really want to, it could be quite frustrating for when you've got this many people, nearly 800 people due to join, that your voice doesn't get heard. So please do use that chat function if you have any comments or any queries. So we will then record that chat, and that will then get distilled into a report that will be produced after this and sent to you for your approval. We'll also be asked if you'd be happy to sign up to that report, because we feel that perhaps one of the things that what comes out of this meeting may achieve is it'll provide some kind of consensus statement on how we feel we should go about what we do. As we go through, so please do ask your questions, write them down, raise your hand. We also have a group of special advisors that you saw listed at the bottom of the first slide, who will be chipping in and helping where possible. So straight on to ethical considerations. We have already some questions that came in overnight, but the basic line with the ethical considerations is much like everything else that you do. It's a matter of the cost-benefit analysis of the benefit of the research that's being done against the cost in terms of potential dangers to researchers, to participants. And there is another particular aspect with this particular consideration at this particular time, and that is that you may well be requiring and utilising PPE that would be better used or is in short supply on the front line. So that includes testing kits as well as PPE. At the very last slide, you will find a list of references and events associated with everything that we're going to talk about today. Amongst that list is a method for prioritizing your research. So you can have a look at that. It's not absolutely specific to physiology, but it may be of some help. The other thing that we have to make a point of is that at this particular moment in time, everything is very dynamic. There are variations in the risk in terms of the people who are most at risk, those that have comorbidities, those of different ages, even those in different geographical locations, not only internationally, but nationally as well. And all of these things will feed into an overall assessment of the risk of doing work. We also know lots of physiologists get involved with respiratory testing, spirometry testing, VO2 max. It's my understanding at the moment, having spoken to Jenny Wilson, our specialist in this area, that actually spirometry and VO2 max would not be regarded as aerosol generating, although maybe that's something that we can discuss when we get onto that aspect to it. So you've seen that slide. These are the questions for the PI really. If I do this study, what has to happen to enable me to do it? And that's what we'll be discussing today. What might happen if I do it? What are the outcomes? What are the likely consequences of me doing that? And how can I mitigate them? You then have to do an evaluation of the value of the study. And then the question, should I do this now, is to do with the priority of the work, whether or not it can be delayed. And that's the essential high-level decision-making tree one has to go through in order to come to a decision. Okay, so that's all I'm going to say about the ethical considerations. We've had one question that I think relates to the ethics that's come in overnight, and it's come from Leonardo and Pierre Tartaruga, and it's from Brazil. Would be interested to have an ethics principle for acquisition in human studies in different areas. What kind of checklist do you need to go through? Well, I hope that we've started to answer that by explaining that, I've spoken to ethicists in the lead up to this meeting, and they are not going to tell you, an ethics committee is not going to tell you that you can or can't do this study. What they're going to ask for is a detailed explanation of the risk assessment that you've undertaken and the mitigations that you've put in place to enable you to do a study. So you won't be able to defer that risk assessment to an ethics committee, but an ethics committee will expect you to have done it and to have established the various risks and mitigations. Does anybody have, from the sort of leadership team here, a comment to make on the ethical aspects before we move on? Or are there any questions, Andrew or Tom, that have come in, or comments about the ethics?
Mike, I could come in if you allow me.
Thank you, Hugh. Yes, please.
So put simply, I think it's the bit that gets forgotten here sometimes is the risk to whom. And the risk is highly variable depending on who you are. So if we talked about the global data, whether it's Wuhan, Italy, or elsewhere actually, or Great Britain, the risk of dying if you contract this, if you're a child or in your teenage years, is better than 1 in 7 million. So children, for instance, and youths tend not to get this much. If they do, they're not really symptomatic to any significant degree, and the risk of transmission to anyone else is very low. So the risk of you sequentially testing people in a lab when they're young and fit is very small indeed. On the contrary, if you're testing 90-year-olds, 70% of 90-year-olds in Great Britain have already died of coronavirus. So the risk is presumably nearly 100% if you were to give it to all of those people. So we're just going to flag this, that we don't have to get panic-stricken about this. If you're older and you're male and you're diabetic or with existing coronary disease or whatever, your risk is substantially higher. But if you're looking at young, fit subjects in their teens and early 20s, if you take sensible precautions, the risk to those individuals, or to you, if you're sensible about how you manage it, is very small indeed. I hope that's helpful, Mike.
That's very helpful, Hugh. Thank you. And I think what we'll do, which will be even more helpful as we go through this presentation, is we'll talk about some of those risks and how to mitigate them. So thanks for that. Andrew, anything to add?
Mike, yes, we have some questions here. One from Declan Ryan asking, could we get a consensus on an ethical approach to asking participants to answer questions on the COVID-19 status or symptoms, for example, as a screening measure? Okay,
well, we'll come on to screening, but just to address Declan's question, we've got a couple of pretty experienced medics on the team. So that's Dan Royce-Dessart and Hugh Montgomery. But my initial response would be just part of the standard history that you would take for any other disease or current or previous existing risk. Is that right, Dan or Hugh? You're muted, Hugh.
I'd agree with that.
Yes, you take it down and then I'll follow.
Yeah. Go, Dan.
If you take a history and the subject is not giving any sort of high risk symptoms in the days or even the 24 hours run up to coming into the, you can be pretty content that a relatively less, and I would advocate, we're living in time, and that we should be developing screening questions based on symptoms actually send out. That's entirely exactly what we're to do with our coming in the Institute of Medicine, is to send those questions out and then to run through them locally at arm's length before they turn up at the laboratory door. Over to you, Hugh.
Yeah, so to pick up on that, Mike, the evidence, 8 weeks ago, we weren't sure about the asymptomatic carrier and the risk of spread. We're very much more confident with that. So it looks as if the majority of people have a short incubation period. So the majority of people have probably developed symptoms within 48 hours or so, but that does stretch out potentially to 6 days. It, however, looks as if most people aren't substantially infective unless they've got symptoms. For the simple reason that firstly, they're not coughing it or sneezing it around places, mainly coughing it. And secondly, because the symptoms relate to viral load. And if you're completely asymptomatic, your upper respiratory tract, which is where this is essentially coming from, doesn't have a very high viral load anyway. So I concur with Dan. If you have make sure that people are asymptomatic, then the risk of transmission is very low. My view is that you treat every single person as potentially infected, because that just makes sense. Just use the sensible precautions, but the risk of infection is low if someone is completely asymptomatic. I agree, Dan.
Thank you, folks. I'm going to move on in the interest of time. But anybody else has some comments or questions, please put them onto the chat and we will address them after the meeting. So just quickly, medical, legal and insurance considerations. Now I think we've had no questions in on this area overnight. But basically, it's to encourage people. At the end of the day, if you don't get ethical approval to do a study, you won't be doing it. And also, if you're not covered by your institution's insurance cover, then you won't be doing a study. So everything else we discuss down line is kind of dependent on this. So it's worth establishing your institution's insurance cover in terms of what they will and will not cover in terms of your experimentation. It's worth asking the participants to check their insurance cover in terms of what they may get engaged in or not get engaged in. And you probably, if you're in the UK, will fall under the Health and Safety at Work Act. If you're an employer, you certainly will. And well, the other aspect, of course, to consider is the people you have in the lab. In terms of your researchers, what's their risk stratification in terms of any comorbidities that they may have. We've talked a little bit about the potential need for resuscitation, which could be a completely random occurrence. And we've talked about we've mentioned aerosol generating procedures, which at the moment, we're going to establish it for certain, but at the moment, respiratory procedures in the lab, Professor Wilson is telling me that such as spirometry and VO2 maxes would not be regarded as aerosol generating procedures. And there are, in the list of papers at the back of this presentation, there are details about the required PPE necessary for resuscitation and the fact that you're basically doing cardiac only resuscitation anyway as standard, removing the need for any airway assistance. So that's really all I wanted to say on that. Do any of the team want to say anything in addition? No? Okay, thank you. Any questions, Andrew, or comments?
I'm just looking through. I don't think so. If anyone wants to ask anything, then please do use the raise hand function, and we can bring you in.
Well, let's go on to the next slide, which is the recruitment and health assessment. And this includes the advice, which is pretty general advice, to move as many preliminaries as you can offline or to remote assessments. Of course, that then carries with it some security issues in terms of people telling you things over the internet. But certainly participant screening and initial consenting, health history questionnaires, etc., could be done remotely. When you're doing a repeat measures experiment, obviously you could keep a daily check on people's symptomatology in terms of their state of health. And there is a consideration for some symptom-free washout periods between participants. The other thing that we'll go on to on the next slide is actually the potential value for testing for the presence of virus RNA upon study enrollment. But before I go on to that testing, do either of our independent medical officers, we've probably got 80 to 100 years of independent medical officer experience in the room. Do they have anything to add to this, Dan or Hugh?
Is that on the testing specifically, Mike?
That's on remote health. So the health assessment prior to testing. So the recruitment and health assessment, the subject assessment, you know, just agreeing that the general principle is to just do this as much remotely as possible. Yes, Dan?
Yes, absolutely.
Yeah, okay, we both agreed on that. You'll have seen this slide, which you may or may not have been surprised by, but generally, to summarize it, that at present, Professor Jenny Wilson, who's Professor of Healthcare Epidemiology in London, advises that actually most of the testing that you might do, PCR testing for COVID-19, is probably of little use in the circumstances in which we find ourselves, and partly because of a lack of sensitivity, partly because of logistics. And it's far better to go, as we've already mentioned, and Hugh's already mentioned, particularly when you're dealing with young, fit individuals, as many people engaged, for example, in sports science do. It's far better to go on the presence of symptoms through the screening as to whether it's safe to continue testing. I don't know if anybody, this may be regarded as slightly contentious, but
I can pick up on that, Mike.
That's not reasonable.
I'll pick up on that, Mike, quickly. So yes,
yeah, okay, Hugh, please.
The evidence we have so far is that viral RNA, which is amplified and therefore detected, can be picked up as long as 37 days after infection. The risk of having infected virus or viral particles that are intact and capable of causing infection is probably about zero for most of the studies after 11 days and potentially as low as 7. So the trouble is you're going to have a long gap after someone has had an infection that's symptomatic, for instance, that they're no longer infected, let's say day 10, but you've still got another 27 days when you might pick up that viral RNA and categorize someone as being infected. Equally, if they've got low viral copy numbers early in disease, you won't detect it. If you screen them, they pick it up the next day, you won't know. And it's for all of those reasons, not least of which the sensitivity, you're missing potentially false negatives anywhere between 5 and 30% of cases anyway. So for all of those reasons, we're not screening people for viral RNA in clinical settings. It's really only for an epidemiological reason to work out how many people have had the infection recently, but we're not using it for clinical purposes at all.
So can we just confirm, to make sure everybody is absolutely clear on what that recommendation is that it's probably of little to no value of testing, doing COVID PCR tests at this time, and you're far better to go on a recent history and the presence of symptoms? Okay.
Correct.
Yes, you happy with that, Dan? Yeah, Dan.
Right, that's certainly the avenue that I think we're going to take at the INM, and we're going to focus on a long lead-in period with people who are going to be into the lab to get them to flag up whether they've got symptoms, to check that the day before they up, but to stop them into the lab. I think there's you in terms of, at this point, it's no more than risk stratification, and we can do that fairly effectively just by doing the questionnaires at arm's length.
Okay, thank you very much, Dan and Hugh. Any comments, Andrew?
Yeah, Mike, Shelby Green has put their hand up, so I will bring them in, and if you could maybe just do say who you are and where you're from, that'd be very helpful. Shelby, that you should be unmuted now.
Hi, I'm Shelby Green. I work at IHMC and down in Pensacola, Florida. And I just had a couple of questions. So one of the things that we do typically in research is to do a background medical history and ask them to do a health risk assessment. Like when they come in, like, have you adhered to this? Have you been sick in any way? Typically when we start our studies. But I noticed that like, how do we determine like some issues? Because it's been noted that people are taking Tylenol to reduce fevers, so they can, appear as if they don't have symptoms. So how would it be a good way to handle that situation? Because we're relying just on the truthfulness.
Thank you, Shelby. Over to you.
I think if people are going to lie, you're in real trouble for testing. If they're going to try and mask symptoms, then you're in trouble. And it's one of the reasons for just treating everybody as if they may be infectious. We used to do those, of course, back in the days of HIV. In the early days, everyone was double gloving and putting stickers saying high risk group. And then we just decided we're going to treat every blood sample as a potential risk. And that's essentially what we're doing now in the hospital, is just accepting that we assume most people potentially are infectious because it's easier to manage. So yes, if they're going to cheat by suppressing their temperatures, there's not much you can do about that, I'm afraid. They're obviously got some other incentive wanting to get tested, I guess.
Right. And so, because I was looking at your slides, and I know that some of the symptoms for coronavirus that you had mentioned here in the percentages, a lot of these have been symptoms of typical allergies that have been really rampant in a lot of states right now because of the season. So, like, are we just kind of supposed to treat everything as if they are infected?
It's a personal opinion. I would, because as you can see from the symptom list, unless you've got absolutely classic ones, I mean, anosmia, the loss of the sense of smell, is pretty specific to this condition and very common. But abdominal discomfort, vague nausea, loss of appetite, intermittent diarrhea, sore throat, headache, confusion, muzzy head, all of these very vague symptoms can indeed be symptoms of coronavirus. So for now, my personal feeling would be if people are significantly unwell in any way, I would treat them as potentially coronavirus, because there isn't another way around it. As you say, even if you tested the RT-PCR and it's positive, it doesn't tell you whether they're currently infected. We're going to have to look for envelope protein for that. But I don't know what Dan would think, or others who have more experience with this than I in terms of lab-based testing.
Okay, thank you.
Thank you very much, Shelby. I mean, my feeling is I would hope that this is a relatively small problem. Certainly people deliberately disguising symptoms. There may be other conditions, as you say, which mimic COVID, and in which case you err on the side of caution and maybe exclude them. Makes recruitment of participants more difficult, but overall it's a good risk aversion strategy. Are you happy with that, Dan? Yeah, okay, Dan's happy. Fine, thank you very much. So
Mike, there was a query here from Ali McManus just around the comment that was made that spirometry and respiratory gas analysis not being aerosol generating, contrary to information coming from some of the lead infectious disease research. So saliva is the primary medium for transmission. It doesn't make sense.
Okay.
Is his query.
Oh, well, that was from Ali. Thank you, Ali. And what we'll do is I'm not sure if Jenny, Professor Wilson has joined us yet. She will be joining us. She's just leaving another meeting. But it was, I think she would be happy to respond to that. So if we can park that for the moment until Prof. Wilson joins us. If she doesn't join us, then we will deal with it outside the meeting unless anybody else has a comment to make. But please remember to keep making your comments between yourselves and to us on the chat function so that we can wrap all this up into a final report. The next slide that you see there comes courtesy of Ben Levine out in Texas. And it really, Shelby alluded to it, it's just a list of the major symptoms of coronavirus, and I've just put it in there for information really, because if we're going to drive our assessment of potential participants on symptomatology, then obviously that's the kind of thing we need to know. So it's really purely for information. Okay, so this is one where I expect we might spend a little bit of time on. Certainly quite a few of the questions we've had coming overnight deal with this, and we'll try and get through as many as we can. We'll allocate 15 or so minutes to it to try and deal with it. Now, obviously, everyone is going to have to be guided to some extent by what the government, local authorities are saying should be done. And this is evolving rapidly. I mean, you know, as we get released from lockdown in the various countries and other things are allowed, then of course this will change what we can do and what we have to do within the laboratory environment. But as it stands at this time, the list of things we have there are reasonable in terms of getting people back into the lab and minimizing risk. I don't particularly want to go through them unless there's anything that people want to pick up on, but they're fairly commonsensical, just trying to endeavor to keep people apart, make sure they know where they're going, they don't get lost, minimizing numbers, minimizing clutter to assist in disinfection, obviously disinfecting things pre and post fairly regularly, the usual requirement for regular hand washing. And then if you're going to have deliveries, having specific areas for those, and increasing the ventilation generally as best you can in the facilities you use. Sometimes forgotten amongst this is field studies, and they come in a variety of forms, from testing occupational groups in the open air through to visiting care homes. And of course, they are quite different in terms of their risks, but generally social distancing in an open environment would be easier and ventilation is going to be better. So your risk there is reduced. But however, field studies where you're going into high risk populations are going to require the maximum use of PPE. I think it's fairly important that laboratories have, which they will already have, a system for reporting adverse events, and also particularly for any adverse events involving COVID-19. So you've had that slide. I don't think, by all means, put some comments or queries in. And what we'll do is we'll run through some of the questions we had overnight whilst you are putting your thoughts together into chat. So under lab. So we had one from Andrew Garrett up in Hull. Hello, Andrew. From a teaching and research perspective, how can we ensure we safely manage student cohorts in a laboratory? I suspect it's going to be small numbers kept far apart. But I don't know if anybody else in the group has anything to add to that.
I could add a generic. We've just got to remember again, this is not any. This is transmitted by spit or blood or stuff on your skin. The way it gets in is upper airways, respiratory tract, essentially. Some deep if it's aerosols, but you're not going to be generating aerosols largely in the lab. So this will be droplets, which means upper respiratory tract, epithelium, and conjunctiva. And that's either going to be because someone coughs in your face or equivalent, or shouts at you, or you touch something and put your finger in your mouth and your eyes. And turn that to that fomite generation or fomite sort of spread in the data we have from intensive care units where everything is absolutely lathered in coronavirus. So we're talking about here infective particles. It's around 17% of keyboard swabs were positive for computers, about 16% of door handles, the tops of the sanitizer bottles around 20%, and gloves, which we wouldn't advocate the use of by and large, 15%. So I think just to remember is if there's enough alcohol gel everywhere in the lab and everyone is prompted to be using it before they come in and at every other point inside and out, you've essentially blocked the transmission by hands. If people do want to wear a mouth covering, at least it means if they cough, it doesn't get spread to everywhere else. And beyond that, if you can maintain the 2 meter distancing, that's not a bad thing to do. But remember, it's 2 meters face to face is the major risk. Side to side is not really as much of a high risk. So again, I'm just trying to inject a little bit of common sense and not panic on this. Hand sanitization, hand washing will dramatically improve everything, and disinfecting surfaces at the end of the day, including keyboards, door handles, and so forth. And a little bit of mouth covering will also help. And if you can maintain the 2 meter distancing, that's a good thing to do as well.
Yeah, thank you, Hugh. I mean, I think the general principle that Hugh's alluding to and that we've discussed before is that the easy way to go with such regulations is to go kind of DEFCON 1 all the time and have people wandering about in labs like astronauts. However, given that the groups, as Hugh has said, that we're dealing with, and given some of the other precautionary measures that one would have in place, I think we're a bit more optimistic about re-engaging in laboratory activity than perhaps others may be. Would that be fair, Hugh?
It would be, and also the data we're getting currently are that gloves spread more infection because they make you feel protected, and you can't routinely wash your gloves in alcohol gel because we don't know how that interacts with the nitrile in the gloves. And because you're protected, you wear the gloves between the door handle, the keyboard, and everywhere else, and transmit things around. So you're better to be not wearing the gloves unless you don't want to, if you're handling blood or spit or something. Yeah. And just remember to keep washing your hands. So those simple measures, the more complex measures, sometimes get in the way of common sense and good practice.
Well, we'll come on to PPE later, and I think we'll hear about that a little bit more. We have a question from Sam Blacker at Chichester. Hello, Sam. When returning to the lab, are there any additional risks or mitigations beyond that we normally follow that we should be taking into consideration when conducting research that involves participants exercising in extreme environments or conducting maximal exercise tests? This is related to both participant safety and virus transmission. I mean, aside from the comment which I think, Dan, you made about the increased potential risk of cardiac related effects of having had coronavirus, putting that to one side and saying, okay, well, if we've got people going into the labs, is there any specific reason why we should be worried about them being in an extreme environment? What do you think the answer to that is, Dan or Hugh?
Well, I could start and then, without wanting to hog the whole thing, let's talk about firstly high intensity breathing, because that's obviously something if we're exercising people very hard. Routine breathing or even breathing hard doesn't increase the risk of infection particularly because you're not creating aerosols. It's coughing, for instance, creates droplets. Ordinary breathing really doesn't create droplets at all. Now, shouting or grunting or singing may in fact increase droplet transmission, and we don't have much data of that. I think there are data from Portland down that may become available. But the best case exemplar of this was the Skagit County Choir in Washington State, where there's been a very good study from America, where there was one index case that infected 53 people in a choir practice. And this is why people are worried about shouting at rugby grounds, for instance, or singing loudly. But heavy breathing in itself shouldn't be a risk. It's definitely not a risk if you've got the person who's doing the testing wearing an appropriate eye shield, visor, for instance, and an appropriately fitting mask in that environment. In terms of other thermal elements, it only really relates to the longevity of the virus in terms of how long they survive on fomites. And essentially raising the temperature kills the virus, dramatically speaking. So if you're keeping around 22 degrees, virus will last about 72 hours on steel, on plastic rather, about 48 hours on steel, cardboard about 24, on copper maybe about 4 hours. But there's a 3 log-fold increase in survival at low temperatures, i.e. 6 degrees. If you're up to 38, it kills it off incredibly quickly. So hot environments, and even hot and humid, lethal to the virus. That's a good thing to virus survival, killing it. But cold, you need to remember to elevate the temperature of the room afterwards, because if you keep it at 6 degrees, you could be knocking out or extending the viral survival into weeks as opposed to days. So that would be the only other comment I'd have on that. But Dan, I guess you have comments of your own too.
Yeah, thank you, Hugh. So one of the things that I read into Sam's question is additional things you might want to think about in terms of subject recruitment and particular questions. And obviously a concern for us from people exercising at very high intensities within a military context is what is the risk to that individual if they've had COVID? We're erring down the slightly cautious route, looking for symptoms of breathlessness, any episodes of chest pain or palpitations or dizziness, having had even a relatively mild of COVID, to make sure that individual actually goes down through a greater degree of cardiac screening before they come into the laboratory to do any maximal testing.
Thank you, Dan. Thank you, Hugh. So, I mean, I think the answer is most people are working in chambers, for example, that most chambers will have the option of going cold and hot. And if you're doing a study in the cold, just push the temperature up at the end of each day for 45 minutes as high as you can get it. And that will be part of your sterilization procedure. I think we're talking about temperatures around about 50 odd plus for 45 minutes, and that pretty well denatures the virus. So if you happen to have a cold chamber that doesn't have a hot option, then you can always buy a pretty effective heater and do it that way if necessary. Okay, thank you. Let's move on, because we've got quite a few questions in this area and I'm conscious of time. What are the recommendations for testing in confined spaces? This is from Steve Faulkner. Thank you, Steve, at Nottingham Trent. Such as environmental chambers, given the increased prevalence of virus. I think we've probably covered that in terms of protective clothing. We certainly will when we go on, and in terms of sterilizing and raising the temperature of the chamber. If you're not happy with what you've heard, Steve, put a chat out and we'll come back to it. We've got a couple from Colleen Dean in Exeter. Thank you, Colleen. And I think this is probably the $64,000 question, although I think it might be, it might not be the correct question, because the question is, when can we expect to be able to go back into doing human testing? Is there a consensus on the time frame for returning to invasive human laboratory testing, for example, muscle biopsies, and what PPE will be required? We'll deal with the PPE later. I'll ask for the views of the other guys on the team, but for me, this is not really a time issue. It's a level of mitigation issue. I mean, there will be some time aspects that will come from what government and local organisations and authorities allow, but to say that we'll be able to restart testing at 4:15 on October the 10th is not really the answer. It's going to be what contingencies and mitigations do you have in place? And as soon as you have them in place, I suspect all other things being permissible that are out of your control, you should be able to return to testing. The analogy I use is the fire brigade don't wait for a fire to get down to 100 degrees before they go and fight it. They are prepared, and they have the equipment necessary to mitigate all those risks, and so therefore they can do it. Anybody want to contradict or argue or support that comment?
I'd agree with you, Mike. I mean, partly over here for Britain, it's going to be political, isn't it? There will be a decision made nationally when students are able to go back to doing things, and when people can meet in more than groups of one or two. I'm not sure whether they'll ever come up with specific guidance about lab testing, but I agree with your comment. In terms of a specific R number, no, unless the R number is going rapidly rising way beyond one or is already approaching the twos, there won't be another lockdown situation again. There may be some slowing processes, but I think as soon as governments say that lockdown is lifted to a degree, you'll be at liberty to do things as long as you've got appropriate processes to stay in place, Mike. And you know, I personally, were we allowed to? Our university hasn't let us go back yet. But with the sorts of things we're discussing today, I don't see the risk as being particularly high. And as a 58-year-old male, my risk as an individual of getting it is moderately high, but I'd still be happy to conduct those tests with the sorts of safeguards we're talking about today.
So thanks, Hugh. So I think, I mean, there's obviously a time component in this, but actually it's a mitigation of risk question as opposed to a time per se question. But Colleen has another one, which is, will there be a daily time limit of human trials? For example, only one human a day max, etc. And I would again come back and say, I suspect that the time people spend in the lab is going to be much more determined by the mitigation strategies that have to be put in place between subjects and participants, rather than there being, oh, you should only test one person a day. Unless there's a viral load issue on the researchers, which hopefully there won't be because of the mitigation in terms of their PPE.
Yeah, I'd say no reason why you can't test as many as you'd want otherwise. The only issue will be, as you're suggesting, Mike, is equipment. So for instance, in our pulmonary function gear at the moment, we are allowed to test normal volunteers, or we're allowed to test patients. We used to be able to do a full set of lung function on 14 patients in a day, but at the moment they're insisting on the kit being fully cleaned in all bits that might give you a virus, and that's reduced us to 4 a day from 14. So if there's going to be a restriction, it will be, I think, based upon distancing, but also on sterilisation of equipment.
We had a couple of questions from Corey Richards, really to do with being in open spaces. Any extra procedures that should be taken to exercise when in a large space, or with social distancing being 2 meters, what spacing would be sufficient to ensure that exercise can take place? Again, I think it comes back to mitigation. If you've got the appropriate PPE, we've got literally thousands of healthcare workers going hands-on with fairly seriously ill patients on a daily basis, and they're doing that because successfully because they have the correct mitigation in place.
Yeah, open spaces are great. You know, the more open the space, the greater the dilution and all the rest of it. And as you say, Mike, just to put this in context again, I've spent 9 weeks absolutely swamped in coronavirus. I haven't, as far as I'm aware, contracted it. To my knowledge, none of the staff I work with have. And we know from the data that even people who work at hot zone intensive care are actually probably contracting a virus if they get it from home or from outside, not from in. So appropriate kit, you're going to be fine. And open spaces, fantastic.
So 3 more questions, really all to do with timing. So we may have addressed these, but I'll read them out anyway, because it does give a feel for what people are worried about at this time. So Andy Garrett up at Hull. Hello, Andy. Thanks for joining us. Appreciate this is difficult to answer in an ever-changing C-19 circumstance, but do we have a projected timeline for returning to the laboratory with student cohorts? And then Colleen again from Exeter, when does it look like studies in healthy middle-aged, over 50-year-olds and over 60-year-old volunteers may resume? And Barney Wainwright from Leeds Beckett, hi, hello Barney, what do you anticipate the circumstances R-value, reported symptoms in tracker apps, etc., at which we might be able to resume lab testing, particularly exercise testing and relax high-level PPE? Might the level of relaxation be related to the participant population or region in which any testing takes place? Could the FISSOC communicate changes in recommended practice? Well, I think we've kind of dealt with that in that once you can get back into universities and once you can get back into laboratories, I don't see, provided you've got the correct mitigation in place, why you should not be able to test, provided the tests you're doing and all this stuff we talked about, ethics and the value of the work, can be justified. I think the really interesting question that comes in amongst all of that is we're, in, as we said, in a very dynamic situation. And as time goes on and hopefully the situation improves, it's going to be the withdrawal of those mitigations. It's going to be the withdrawal of the level of constraints and PPE, for example, that is going to be difficult. Can the PhysSoc comment on that? Well, what I hope the Physiological Society will continue to do what they've done thus far, which is support as best as possible the clinicians at the front line and now the physiologists trying to get back in the lab to do their essential research. I don't think, can we, guys on the sort of team, I don't think we can say that it's going to be at this particular R value or it's going to be at this particular level of infection. I think it's going to be much more to do with we do what we need to do at this stage, and then that will be relaxed as the overall infection rate and R falls. Yes, Hugh.
So yes, I'd agree with that. And to pick up on the point made specifically about 50-year-olds and over, I picked up on John Castellani's comment earlier on as well, and with which I concur and would reiterate that I think we just treat everyone as potentially infectious and we treat everyone as potentially at risk. And we just, as long as we behave sensibly, I personally wouldn't be differentiating a 50-year-old from a 25-year-old. I know the risks to be at 50 or 58 are very much higher than if you're 20, where the risk is virtually zero. But nonetheless, let's just be sensible and treat everyone the same way. And as a potential subject, if Mike asked me down to Portsmouth to be a subject in his lab, where I've been a subject before, with the appropriate things in, even now, I'd be very happy to be an experimental subject, because I don't see that there's a great risk to me if there's sensible precautions in place. I see Jenny's joined us as well, Prof. Wilson, who is a world expert in infection control. And I don't know if Jenny, Mike, you want to invite her into this?
Yes, thank you, Jenny, for managing to join us. I know you've been topped up with meetings. And we've already had a couple of questions that I've managed to slope shoulders to you, so in the hope that you would turn up. And I think they'll come to the fore when we go into the next section. So I'll hold them for now.
Yeah,
but we did have I think we had a question from Shelley, which we may have to reiterate. Andrew, is there anybody with a burning desire to ask something on the topic of laboratory practice, or feels that...
well, there have been quite a few comments around the issue of ventilation and how critical it is that fresh air via open windows as opposed to air conditioning is used. Yeah, there have been quite a few questions just on building systems and the remix of fresh and extracted internal air and what the balance is between that.
So one of the references, I think, at the end of this slide deck is from the ventilation guys that talk about ventilation. I mean, obviously, yes, the disinfection through heat we've talked about and the flushing with fresh air. I don't know if Dan or Jeff Long have anything to add to that. I mean, clearly you've got to be careful where you're venting the laboratory air to. If it's not a closed system. Hugh?
Well, only in as much as there was a bit of a scare put out on the business of the cruise ships. And the scare that was put out was that there was clear evidence of non-droplet spread through air conditioning systems. And that's been debunked. The spread was from direct contact or from fomite. So currently you're not doing aerosol generating procedures, and droplets really won't be winging it around the building from air conditioning systems. And there's no evidence to suggest that that's the case anyway. Remember, this is largely droplets, and these are heavy droplets. They don't hang around in the air. If you do aerosolize them, they hang around for potentially 3 hours until they're all gone, 1 hour until half of them are gone. But you're not doing that. This is a droplet issue. So this business of high exchange rates, maybe 6 to 8 an hour, that we would require in an aerosol generating procedure area, such as an intensive care unit, I don't see as being necessary in this circumstance. But again, Jenny may be able to comment better on this.
So the thing about ventilation is that it just helps disperse the aerosols. So in a standard room with the window open, you will easily reach 6 or 7 air changes an hour, because the natural flow of the air just circulates it. And that is just an important way to distribute those any droplets that are generated. You dilute them out, and by diluting them out, the chances of you inhaling them diminish dramatically. But you know, there isn't anything special about it, and the more windows you have open, the greater the turnover of air.
Jenny, whilst you've got the microphone,
Yes.
we were talking earlier about respiratory aerosols, and I sent you the question: would running a VO2 max on a treadmill with a mask with, say, a flow meter in it, or doing spirometry, be regarded as an aerosol producing procedure? And your answer was no, which is, I think, probably might be make a lot of people fairly happy. Can you just elaborate on that a bit?
Okay, so I think my initial response was, I doubt it, but that was sort of because I was on another call at the time and I couldn't find the documents to send to you. I don't know precisely how you do it, but the documents that I sent you were a recent review done by Health Protection Scotland of the issues underpinning aerosol generating procedures, which I think is really helpful because it illustrates the extent to which there is little. So there's a difference between having no evidence and having evidence that tells you something. So the evidence about aerosol generating procedures comes from SARS, and really the only procedures for which there is evidence that they generate aerosols for which a higher level of respiratory protection by those involved in delivering the procedure is required are intubation, tracheostomy, bronchoscopy, and I think that's about it. There is a longer list of procedures that are assumed to be aerosol generating, but the principle is that if it's going to generate respiratory aerosols, the procedures where it's known to do that involve the passage of air at high velocity over the respiratory mucosa. So many other procedures that people sort of assume will result in the generation of significant amount of aerosols do not do that. And often the confusion is about procedures that generate coughing. So many things that happen to people, investigations result in the person coughing. Coughing, we know, increases the risk of transmission, but that is through the generation of respiratory droplets. And that is where a face mask or a face protector prevents those droplets that are released during coughing ending up on the mucous membranes. The procedures, the aerosol generating procedures, generate tiny particles from deep into the lung tissue. And the problem with those is they are more likely to become airborne and they are smaller. And because they become airborne and are small, you can inhale them. And there is a small risk that they may go through the side of the mask because they're tiny and they remain airborne. So the important thing is to distinguish those procedures which are likely to generate those large amount of tiny droplets from deep in the lungs. And that's where the aerosol generating procedures come from. Now, you mentioned spirometry. That's definitely not on a list of aerosol generating procedures. The other procedure you mentioned didn't sound like it, but you could run through what they do and we could evaluate the likely risk. It's certainly not on a list, but sometimes you can sort of equate a procedure and say, well, that's so similar to this procedure, which we know is aerosol generating, that we'll think that it is.
So any form of maximum exercise where you are getting people to ventilate at very high levels, deep breathing, higher frequency, but probably breathing in and out of a mouthpiece or in and out of an oronasal mask with a flow meter in it.
Yeah. So the only thing I would worry about is the equipment that they're spitting all over. So I wouldn't worry. That is not going to generate aerosols. So that actually sounds very similar to me going for a run. There's a lot of heavy breathing involved. and I'm sure anybody who gets within 2 meters of me gets some of my respiratory droplets, but that is a respiratory droplet generating procedure. And yes, sure, it will generate them and it will contaminate the environment around that patient at the time, but the droplets will drop to the floor fairly rapidly, and then it will definitely contaminate any of that equipment that they're breathing into.
Yeah, we will come on to that in a moment. And just to say thank you very much, Jenny, that Jenny gave an excellent answer, written answer, to a question from Stacey Hutton on precisely these issues to do with droplets and to do with aerosol generation. And we won't go into that now, because we've heard directly from the expert, but the answer to that question will appear in the follow-up report. That takes us nicely on to the infection area of things. And you've had the slides, so we don't go through these in any great depth, but we've kind of been touching on all of this as we go along. There is a lot out there on filtering and disinfection, so I'm not going to bother you by going through this in any great detail. We've heard about vigorous hand washing. We know which solutions to use. We know which filters to use if you need to use them.
Mike, just one quick comment on this again. Could I chip in, Mike?
Yes, please do, Hugh. Yeah.
Just remember that soap is highly effective and detergent. It activates the viral coat and it cannot infect anybody. So soap and water is fine. And I'm just making the point because people get terribly worked up about clothing. And we're on the wards when we're not in the red zone. We're seeing patients that may well be coronavirus infected. We're wearing our own clothes. I'm not remotely worried about that. And they go in the washing machine, but not necessarily even that night. Unless you've got a very heavy viral load and wanting to flap it around the place, it's not a major issue. Just remember, soap and water is good stuff. Alcohol gel's more convenient.
Thank you very much. We'll come on to the PPE bit as the final area, I think. So I think we've got a couple of questions on disinfection, but before we go on, Andrew, is there anybody bursting to ask a question or say anything, or is it all happening nicely offline?
There's quite a good conversation going on. If anyone would like to speak, would encourage you to use the raise hand function and we can bring you in. But yeah, the conversation is going well, and please continue to put comments in the chat function if you would like not to have the video and audio.
Okay, so thank you, Andrew. The disinfection and filtering aspects. We've had a question from Todd Pryor to do with cold rooms, moist, cold places. How could they be decontaminated properly? We'll talk about the PPE requirements. We've already touched on that in terms of raising the temperature as best you can, even if it involves bringing in a hot air blower or just getting the temperature as high as possible for as long as possible. I don't think there's anything we can add to that at this point, but please follow up, Todd, if you want to send a supplementary question in. We had a series of questions from Stacey, as I say, and I think they've pretty well been dealt with. The one area of disinfection that I think I've seen on the Slack website that has successfully been looking at these kind of questions has been the disinfection of some respiratory equipment where there is sample lines that feed back into the system. They will clearly need to be disinfected as well as they need to be disinfected, or the sample lines changed or replaced. I don't think there's any, I don't know what the conclusion to that debate was. Maybe somebody can put that into a chat answer. Okay, we've got still about 30 minutes to go, which I think we may need, although I think this is probably a bit more straightforward than people have made out. People have got slightly confused about PPE. One of the confusions appears to be, and I'll be very happy to take some input from Hugh, Dan and Jenny on this, is quite a lot of what you see is obviously airway protection, head protection, aprons, but there's very little mention about the rest of the clothing, trousers, footwear. When I've spoken to GPs about this, they tend to wear scrubs underneath that they change out of and wash at 60 degrees at the end of the day. They disinfect their clogs or Crocs, and then they change into their gear to go home. So I'd be interested to hear what people have to say about that. I'm not going to spend too long on this, other than there is some training required, and actually there's some very good training on donning and doffing PPE can be found online, and there's a link provided by Prof. Mekovic, actually, which you can find at the back of this. Normally, you're talking about, now interesting, this is where we'll get Jenny, but prepare yourself, Jenny. This is where we get the standard recommendation for apron, gloves, fluid resistant surgical mask, hand washing before and after intervention. Good fitting is important, which is why the training is important, and goggles for eye protection. Now, we might as well deal with the glove issue now, Jenny. Do you want to just say a few words? Okay. Because it's popped up a few times and it sits right in the middle of this slide.
Yeah, so the thing about gloves is, and I think I articulated this in an email to you, so forgive me if I don't articulate in exactly the right way.
Yeah.
And basically, I'm not really quite sure why PHE/WHO added gloves for contact with patients with COVID, because the virus doesn't go through the skin. The standard approach to wearing gloves in healthcare settings, the guidance is and always has been that you wear gloves for direct contact with blood and body fluid. The rationale being that body fluid contains high concentrations of pathogens, and therefore it makes sense not to get those onto your hands. Now, you can argue that you should wear gloves for direct contact with respiratory secretions because those will contain pathogens, but that fits in with a standard precautions approach that you would wear gloves for contact with blood and body fluid. There is no reason to wear gloves for contact with surfaces, with people, but it has become fairly commonplace across healthcare. You only need to look at a TV program based in healthcare and you see practically everybody wearing gloves, but there is no infection control reason for doing it. And in fact, quite a lot of the research that we've done has focused on the use of gloves, and we find that what happens is people put gloves on and then they don't change them. And it's particularly commonplace in places like radiography, clinic environments, where people will put gloves on and then be touching dials and equipment with the same pair of gloves on, touching the patient, touching the bed. So you are just moving the pathogens around from the patient to everything that you touch. So a far better form of practice is to wear gloves if you are going to have contact with blood and body fluid, but at all other times you rely on hand hygiene to remove that contamination. So if you touch the patient, you're organising them to undergo whatever test they're undergoing, or you're taking a test, you decontaminate your hands before you have contact with them. And then as soon as you finish that contact, you decontaminate them again. And that's why gel is so useful, because you can just squirt the gel on your hands, decontaminate your hands, job done. If you're wearing gloves, what tends to happen is people put a pair of gloves on and then they never decontaminate their hands, and they rely on those gloves because they feel they're protecting themselves from the gloves, with the gloves, but actually what they're doing is just spreading pathogens about the place. So in this situation, you are working with people who you do not believe have COVID. Some of them may do, they may be asymptomatic. It's highly likely to be very small numbers. And my advice would be you rely on hand hygiene before contact, after contact, definitely before you touch any of your own mucous membranes, that you've always got clean hands, and you are better protected that way than relying on gloves.
Thank you very much, Jenny. I saw lots of nodding from Hugh, so I'm pretty sure he agrees. The last point on that slide, we've now established what isn't aerosol generating, which is useful. So that I think will help some people. That's just to remind me to say there's lots of training about how to wear PPE, and there is some risk stratification and the consequent requirement for PPE. This comes from Ben Levine, and you've got the slides, everyone's got the slides, so they don't need me to go through them. There are other ways, obviously, of risk stratifying in terms of PPE requirements. And I know that, for example, Chichester, Sam Blacker has told me that Chichester are doing it against the COVID-19 alert levels. So there are ways of doing it. There are fairly recent recommendations that you can find in the first or second reference on the list of references at the back of this deck, on the level of PPE you require for different interventions and different settings. I've put them all in. I think probably the one that may well be of most use is the last one of those, the one you see here, when you're essentially at fairly low risk of having somebody that you believe to have COVID-19. So please use that and consider it as you will. We have some questions on PPE. So there's one from Stacey Hutton from the Canadian Sport Institute, Pacific, Canada. Is there sufficient validated evidence to ensure labs are taking proportionate steps to prevent transmission? Is there sufficient validated evidence to suggest that labs are taking proportionate steps to prevent transmission, use of gloves, aerosol transmission, sterilisation of equipment, etc.? I don't think there is, because I don't think we're in a situation where anybody's doing very much at the moment, but I'm happy to be corrected by others.
I think the question also arises about who's transmitting to who. So, you know, people often worry about acquiring it themselves, but they worry less about the risk that they will transmit it to people who have come in for tests. So it's really important to look at it both ways. It isn't just about protecting the staff, it's also about assuring if they have close contact with other people who've come in for tests, that they are taking steps to protect those people coming in from exposure to it in that environment.
Thank you. We've done the gloves question. That's well and truly done. There's one from Paul Mullins in Bangor. It would just be useful, I think, to just very quickly talk about the possibility of reusing PPE, because of course this is going to add an enormous amount of cost to most people's research budget. So where are we with reusable PPE? And we might as well wrap up into that, the difference between single-use PPE and single-session PPE. So if we can just have a couple of words about that. Incidentally, the single-use PPE and the single-session PPE definitions are included in one of the documents at the back of this slide deck, where gloves and aprons being single-use, and as I understand it, respirators, fluid-resistant surgical masks, eye protection, disposable fluid repellent coveralls, long-sleeve disposable fluid repellent coveralls are single-session. Does that sound about right, Jenny? Yeah,
I mean, certainly gloves, single use only, and they should be used for one task and discarded. Aprons, you can use an apron for contact with a patient or an individual for that session of care for that individual person. But if you then leave that person and go on to somebody else, then you need to take the apron off. Masks can be used for, so say you're doing a whole series, you can use the same mask the whole time, because the point of the mask is it's preventing your respiratory droplets getting into the people that you're having contact with, and equally protecting your mucous membranes from those people that you're having contact with. So you can wear it for a prolonged period of time. You have to change it if it gets wet, because it loses its filtration properties. To be honest, the worst thing about them is they are incredibly uncomfortable to wear. And so the longer you have it on, the more likely you are to fiddle with it. And as soon as you start fiddling with it, you run the risk of just transferring pathogens from your own mask onto your hands. So if it becomes uncomfortable, you're better just taking it off and throwing it away. You do not want to do what you see loads of people doing, taking it off and hanging it around your neck and then just putting it back on again, because again, you'll just pick up all the pathogens that you've breathed out into that mask onto your own hands. Face protectors actually may well provide a practical option. At the moment, they're not really being recommended. I think there's a lot of room to develop more effective face protectors. And those are good because you can decontaminate them. They're made of plastic, and so you can just wipe them clean periodically through the day, the end of the session, and so on, or between different uses. Gowns, I have more concerns about gowns. I know people talk about them being sessional, but actually if you have a lot of close contact with somebody, unless you protect that with a plastic apron, it just then becomes a vehicle for transmission. So if you're going to use gowns over a period of time, and they'd only be indicated if you were at risk of getting body fluids splashed on you, or you were doing an aerosol generating procedure, you must cover that with a plastic apron so that you don't just then transfer pathogens from one person to another.
Thank you, Jenny. I think we've covered also as part in the conversation the question we had from Leonardo, who I mentioned earlier, from Brazil. So how can I lead as a principal investigator with data collection procedures using biomechanical evaluations? Well, with the correct PPE, as we've just outlined, there's absolutely no reason why you can't move within 2 meters of an individual and lay hands upon them. It's happening day in, day out in many hospitals around the world. And I hope now you've got a good feel for the PPE that you would use. But just to put a final point on this, Jenny or Hugh, Dan, if we're going to go back to the lab and we're going to do hands-on experimentation, physiological experimentation on people that we've screened, we believe that they're young, fit and healthy, what level of PPE would you recommend, given that we might be doing exercise testing, it might be a thermal study, it might be a metabolic study? What would you regard as the basic level of PPE necessary just to get back and do standard physiological testing and physiological teaching in a laboratory environment?
Well, I'll let Jenny answer in a second, because she may have a different view, and that would be helpful if we agreed or differed. But my feeling is no gloves, washing hands, everyone, usual stuff, alcohol gel before and afters for everyone. I wear goggles always, and that's not because I'm worried that someone's going to cough directly in my face, but where it would protect me from that. But it stops me rubbing my finger in my eye accidentally and spreading it from a surface. So I wear goggles as a matter of routine, and a surgical mask is fine if we're going to just make an assumption that everyone is transmitting it, because that's way, if they're wearing it, if they can, or if they're wearing a mask or a mouthpiece, you don't have to worry anyway, because they're not going to cough it on you. And the only reason for you wearing a surgical mask is because you might have picked it up at home and might be spreading it to them. But beyond that, this is not an aerosol generating environment, and you're not going to need FFP3 and water resistant, water repellent, everything. So I wear no gloves, alcohol gel, pair of goggles, and surgical masks. That'd be my view. But Jenny, you may have a different one.
You are now an honorary member of the Infection Prevention Society.
He probably already was.
I absolutely, totally agree. That is just perfect. And I think the thing about the face mask is, at the moment, I think that's what we need to do. It's a way of socially distancing during a procedure where you do need to actually be relatively close to somebody. So perfect, totally agree. I would say about the clothing, somebody else picked this up, that I agree with you, Hugh. You may pick up a bit of contamination during the day just as you're working. And it's sensible to have work clothes, i.e. things that you wear at work where you have a lot of contact, you might get contamination on your clothing. Those are your work clothes, and you just take them off, stick them in the washing machine. Washing is just the best way of getting rid of any pathogen, but dilution's really important. So don't stuff the washing machine full to the gunnels and expect it to clean. It cleans by you putting detergent in and then having a whole lot of water going in and washing everything off and flushing it away. And as long as you do that, it's fine.
And then the recommendation would be to do as we currently do, which is add gloves if you're bloodletting.
Correct. Yes, and also for handling that, any of those masks or face equipment which may have saliva and respiratory secretions on it. So anything like that where there's a risk there might be body fluid contaminating it, just put on gloves for that, clean it off with the gloves on, and then discard the gloves, and then you start with the next patient. Wash your hands, start with the next patient.
And to be absolutely clear, when you say body fluid, we're talking about respiratory body fluid.
Yeah, so any body fluid, so feces, blood, urine, respiratory secretions, in the sense that, you know, often when people are doing procedures like that, they'll have an awful lot of saliva and gunk they've coughed up. So anything that you are going to get gross contamination on your hands, if you can avoid touching it, that's perfectly okay. You don't need gloves then for those procedures. And just touching people's skin, touching the environment that they're sitting in to organise them, that's absolutely fine. Just wash your hands.
Thank you, Jenny. I mean, I'm not going to go through the lovely answer you gave, but we'll incorporate this in the final report. You haven't contradicted any of it, which is
that's good. That's good.
Just before we finish, I want to go back to a slide which I jumped over because we'd gone on to infection, and talk a little bit about experimental design. And because the other thing that may be one of the mitigations or the requirements as a result of a mitigation for this is that we end up doing slightly different science. So rather than having people coming in over 2 weeks doing repeated measures, we might end up doing, between cohort tests. I don't know, Professor Mekiewicz, are you there or thereabouts? Is there anything you want to add to this slide? Which wasn't in the original deck, which I stole from you when you sent me your comments on my deck.
Yes, thanks, Mike. It's also an issue of statistics. I'm not a statistician, as you know, but obviously, if you the experimental design will then obviously demand certain type of statistical analysis. And I think that if we look at the experiments we normally do, it's either single intervention, repeated measures. And if you're doing a single intervention, then I think what you discussed in the first few slides about the precautions that need to be taken when you recruit subjects and actually monitor them after the experiment, I mean, I think that's fine. But I think the repeated measures one, where you're asking subjects to come in several times over a certain period of time, that becomes a bit more difficult. So you have to basically treat them every time as a new intervention. So you have to go through the whole procedure probably each time. Now, the point I said was, if maybe you should go to group comparisons. If someone was in an institution that required, let's say, testing every single time, then of course that's a large cost. So in that case, you might be, and also an annoyance. You might want to consider then doing more like group comparisons. One thing that we've sometimes done in some experiments, which is frowned upon by statisticians, is where you actually have a subject repeat the trial several times. This is called quasi-replication, and perhaps not, it's kind of acceptable, but in this point of time, I think it's also something we need to consider. So on some of these issues, I would prefer to sort of hear from a statistician what they think. In terms of some other experiments we've done, we do confinement experiments. Sometimes when you do, for example, acclimatization studies or some of the bed rest studies we've done, you actually confine not only the subjects to, say, a period of 10, 20 days or more, but you also can confine the researchers. So there the risk is low, because once you enter the confinement, that's it, you're there. There's very little interaction with the outside world. But then since we have this facility, we've often considered that if you do a repeated measures design, let's say you need to do a repeated measures over 2 or 3 days, well, would it be reasonable then to use the dormitory or some kind of confinement area where you house these subjects during this time? So they live there, you provide food and everything, and that way you're limiting their basically interaction with anybody else, and so that's and minimizing infection. So these are just things that I mentioned that one should maybe consider, is rethinking the design of experiments to minimize the risk.
Thank you. I think that's an important consideration in amongst everything else we're doing. So thanks for that, Igor. Andrew, did we have any comments, complaints or questions as a result of our discussion on PPE and that last aspect on experimental design?
Nothing specifically on that. Carolyn, I know that you put something in the chat. I don't know if you want to come in and say anything. If you would, then please do. I see that Paul Mullins has just put his hand up as well. So I suggest we go to Carolyn first, because I see she's unmuted herself, and then go to Paul after that. Carolyn.
Yes, thanks everyone. And it's absolutely amazing that we've had so many people join, and the chat's been really, really interesting. And I've been trying to respond to the questions about ethics because I have a particular interest in that. I'm also a physiologist, and there have been some really nice suggestions about, you know, checklists and decision trees to help us come to our own decisions about, you know, as Mike said earlier in the slide deck, you know, should we be doing this research now? My last question was just, it's a very sort of broad ethics issue. I mean, I think in terms of research ethics committees, you know, you explain to somebody exactly what you're going to do, and you tell them what the risks are, and they're informed. And so at that level, it's fairly straightforward. But I just had a wider question about whether, you know, this is a virus for which there isn't any treatment at the moment, and whether we should be exposing ourselves and other people or other people to an elevated risk. And maybe that comes from my own background, of course, which is working with people with frailty, very old and immobile in many cases, participants. So I just want to leave people with that question.
Thank
If
you.
I could just chip in there, just as a comment from the health side, the risk isn't really elevated. The evidence in hospitals shows that where there's even very, very high density of active virus, with sensible precautions, the risk is actually lower than it is outside. Mm-hmm. As I say, the health tracking data, James Moon's study in the Lancet, was showing that the prevalence of infection didn't track with the numbers going up steeply just after lockdown inside hospitals. It tracked very tightly with the prevalence outside in the community, because you're very safe in a lab. If you're using cold gel, washing hands and using these measures, the risk of contracting infection is very, very low. You're much more likely to contract it catching the bus in or going to Tesco's and buying a sandwich on the way home.
Thank you.
And then
Andrew.
could we invite Paul Mullins to come in?
You know, my comment, it's not really important. It's just that I noticed the chat function had been disabled. So there may have been a lot of people that wanted to add things that they couldn't do because, I don't know, maybe the chat was getting a little too large. Just want to say this has been great, very useful. Thank you very much.
Okay, thank you, Paul. Thank you, Paul.
The chat, I'm not quite sure why it was disabled. Maybe it's because maybe it was the size, but it's reopened now. So if anyone has anything they would like to add before we finish, please do put it in the chat box, and we'll make sure everything is captured.
You make sure you make that point on the chat box, Paul, because we don't want to lose that. Thank you very much for your kind words.
Mike, may I ask a question of Jennifer and Hugh, please?
Yes.
It's relating to the comments we had before regarding environmental chambers, and there were quite a few questions on this. So as far as I understand, the actual ventilation in a building has very little to do with the distribution of the virus. So that means if you have an environmental chamber, you don't actually have to have the how should I put it, the ventilation on. You just really need to heat up the room, not necessarily the entire system. Is this correct?
Yes, essentially the droplets won't have been spread. Assuming you're not doing something weird that's aerosol generating, and that is things like tracheostomies and things which I doubt you're doing. The droplets will be on the surfaces, and as we've discussed earlier on, that they're very heat sensitive. So if you crank the temperatures up, say the study's going even from 20 to 30 odd degrees makes a huge difference. If you're cranking it up beyond that, you'll kill the virus very quickly indeed. But the air conditioning itself doesn't seem to be a mode of spread for normal individuals. And in fact, it doesn't appear to be in the hospitals either. So for instance, in our intensive care units, we haven't converted all of those to negative pressure systems with isolated ventilation circuits at all. We just shut the doors and the normal ventilation is in operation, and there's no increased risk outside that intensive care unit.
And even in a negative pressure ventilation setup, really the key is still about dilution. That's what you're really aiming to do, is just direct the airflow and just keep changing it so that you dilute out the particles and you render the air safe by diluting out the particles. There was one SARS outbreak that involved a major sewage leakage in some big block. And that was thought to generate or distribute aerosols through the building to a number of people. But that, I think, is a nice illustration of how this is not going to happen in a normal situation, that it requires highly unusual situation where you get high levels of gross contamination in order to get sufficient aerosol in the air to render it that hazardous that it's going to disseminate outside the immediate area that you're doing the procedure.
Thank you. Thank you for your question, Igor, and thank you for your responses, Hugh and Jenny. Well, I'm afraid, folks, that brings us to the end of our time. I do hope you found this of some use. What we have done, as we said an hour and a half ago, is we've recorded this, and we've also recorded and saved the chat. And what we now will do is to try to combine those aspects into a report. We'll try and do that as quickly as we can, and we'll send that out to everyone who registered for the meeting. We'll hopefully include all the aspects, the questions, and the responses to those questions. So I'd like to say a particular thank you to the Physiological Society team for supporting this, and also to the guys and gals that volunteered to come and help with answering the questions. So thank you very much, all of you. If you want to get down into the nitty-gritty of some of the aspects of what we've been talking about, there are your links to all of those aspects. And also, it may be of interest to you to know that on the 1st of June, there is a webinar looking at working safely in laboratory facilities. So with that, I'll say thank you very much for your input and for your help. And we look forward to getting back into the laboratory very soon. Goodbye.